Hi, everybody. I'm Brianne. The Northern Health Equity Strategy, published in 2017, showed that there are pretty substantial differences in our traditional population health outcome indicators. So our life expectancy is lower, variable west to east. We have higher rates of hospitalizations for most conditions, emerge visits for most conditions, person years life loss. So, for the epidemiologist and evaluation people, our pop health indicators do look worse among commonly measured outcome indicators. And so this health equity strategy was great because it came out with specific recommendations about how we can begin to address this with a collective and Northern specific approach. Hospitals play a huge role in our Ontario health teams in Northern Ontario, that there is no dedicated healthcare strategy. So flagging, we need to consider the Northern context as a reason to specifically plan, implement, and evaluate programs for Northern populations, communities, and health systems. A little bit about what the Northern Ontario context is. We have 11 Ontario health teams. I screenshotted Inspire's website to give you a little bit of a sense of where they are, where the service providers are, although that we have some challenges with as well. We do have 3 in the initial 12. Primary care is often the only care. And I actually, again, screenshotted this picture from a 2011 ICES report. And so those little red dots that you see, people living in those communities have to travel over 60 minutes to see a primary care provider. Sometimes it's the only care, and it might be delivered in unexpected places. So we collaborate. So this isn't all about all the gaps and disparities and inequities we face. There are a lot of strengths that Northern populations, communities, health leaders demonstrate, and collaboration and connection to our communities is one of those strengths. And also, I keep talking about Northern Ontario as though it's a singular entity, and really it's not. We are incredibly diverse. There are over 100 independent First Nations communities in Northern Ontario. There are heavily Francophone areas. We do have some more in our urban centers. There are higher immigrant populations, but just by the reality of being in the north, we are often thought of as a singular entity and other to perhaps the more mainstream Ontario population. What is unique about this context? Why is it important? And so I've included the Learning Health System Action Framework here too. And so we do have a smaller workforce, and that leads to generalists. We have a lot of generalists. We hear that in clinicians a lot. We hear rural generalists because primary care providers often have to wear the hat of specialists. And so in the evaluation context, that means that our evaluation experts are also going to be, doing the QI, doing the reporting, being project managers. Perhaps they're clinicians, wearing so many different hats, and that has implications on the kind of work that we do and how we work together. And again, we collaborate because we need to, and we're good at it. So a lot of what I'm talking about is actually working between and across Ontario health teams. And our pop health profiles, our priorities, our needs are often different from, say, the provincial average or the provincially stated priorities. And so that's something that we have to balance. How do we move these provincial directions forward, or even regional priorities forward, when we have to also focus on what is most important to the populations who we serve? And I'm coming from Nauset University, but I work with some of the other academic institutions up here, other universities and colleges, and they explicitly identify that they want to be socially accountable. And so being accountable to Northern Ontario means providing value and the communities finding value in what they produce. And so there's the embedded, the value of an embedded evaluator or researcher. So team-based worked best. I've heard the others speak about that as well. Capacity building is part of the strategy. So we're trying to, democratize evaluation, but how do we make sure that others are involved and engaged and maybe eventually can independently help create those logic models or data collection strategies, without necessarily the support of the, whole team. Data collection is inevitable. Again, I've heard this now from both previous presenters. Walter alluded to it too, and know the so what ahead of time. And yeah, Reham really spoke to this, and as does the learning health system action framework. Is once you have the data, you have to do something with it. So what are we going to do? And I think that that's really important too. So with that, thank you.